Welcome to this second webinar entitled A Scoping Review of NHS Patient Information Guides about the use of force. This second webinar follows on from Report 1, Scoping Review of NHS Restraint Policies in relation to people with learning disabilities. That first report and webinar provided the wider context of the research findings. So once again, our thanks to those that supported this research, who are shown there on the page. And for more information about those organisations, please refer to the first report and webinar. So let me give you some intro to this report and explain the structure. So this report is going to start by briefly describing how we collated and analysed NHS Easy Read Patient Information Guides, and then we will present the results from the quantitative and qualitative analysis. However, before we do that, we will discuss something around the types of patient information guides that were available, and we'll look at some outliers and highlight two easy read guides in particular, for reasons that will become apparent when we discuss them. And then we'll go on to analyse the 14 easy read guides from NHS Trusts that were made available to us. Throughout the finding, there are 11 recommendations which together advise how NHS Trusts can co-produce easy-read patient information that complies with the guidance and appropriately informs patients. So a little background before we get started. At the time that this report was written, NHS Digital was reporting that 2,020 people with learning disabilities and autistic people were in inpatient services. That was at the end of October 2025. And that 51% of those had had a total length of stay, which was over 2 years. In that same month, 720 of those patients were restrained a collective 7,615 times. The requirement to co-produce accessible patient information is for the individuals behind those numbers and their families, that they should know what is happening and why, what their rights are, and where to get support. The research was conducted with the current reality of inpatient admission of people with learning disabilities held in mind. Information about the use of force should be provided to patients and, where appropriate, their families and carers. This is made clear in Section 4 of the statutory guidance accompanying the Mental Health Unit's Use of Force Act 2018, hereafter referred to as Cheney's Law. And the overarching goal of that patient information is that patients and families should have a good understanding of what might happen to them while they're in an inpatient mental health unit, what their rights are, and what help and support is available to them should they need it. So this guidance from Cheney's Law essentially gives us the overarching goals for easy read patient information and formed the basis of our analysis of the patient information that we received. So in 2025, we conducted freedom of information requests to 48 NHS trusts that were running mental health units and asked for their patient information that they were using or making available to their patients. We noted that we were particularly interested in sourcing good practice and how people with learning disabilities are supported when they come into NHS mental health units. Information on use of force for patients was obtained from the responses received, and we also ran some trust website searches to see if there was anything additional. And the results were that we collated 36 examples of patient-facing information about Cheney's Law or the use of force. So in terms of our quantitative analysis, we simply asked, did the Easy Read Patient Information Guide address these topics? And you'll see 11 topics appearing on the screen there. Section 4 of the guidance lists the content required in patient information, and that list informed the creation of these 11 criteria against which Easy Read patient information was RAG rated. So that's how we conducted the quantitative analysis. In terms of the qualitative analysis, we followed the advice from the advisory board and focused our quality assessment on the definitions of restraint, types of force, involvement in care planning, post-incident debriefs, advocacy, and concerns and complaints. So those were the 6 areas where we did more of a deep dive and looked at the quality of the content in the guides. So if we start by simply looking at an overview of the patient information that was made available to us. The statutory requirement states that it's important that patients and, where appropriate, families and carers are provided with information about the use of force and their rights in relation to any use of force that may be used. And then it goes on to say that that information should be tailored to the patient population using the service. So we found that 18 trusts, that's 37.5%, had a patient leaflet, but no easy read. So just some patient information that had not been adapted for any particular needs. And then we found that an additional 18 trusts had produced a patient information leaflet, which appeared to have been designed with people with learning disabilities in mind, although not all of them were using a traditional easy read format. So that meant that 75% of trusts had some kind of patient information, leaving 12 trusts, 25%, that had no patient information leaflet or easy read that we could find, as in nothing was sent to us in response to our freedom of information request, and there was nothing available on the trust website. So Cheney's Law also recommends that those guides are published on the website, and we found 6 easy read guides that had been published on the website, which is the equivalent of 13% of trusts being compliant with the recommendation that tailored patient information about the use of force would be available on their website. So our first recommendation is simply that trusts publish an easy read patient guide to the use of force and that they have it available on their website. So the rest of the report will break down what we found from the adapted or accessible guides that the 18 trusts did make available to us. Whatever is said about the quality of those guides, it's worth holding in mind the number of trusts who were unable to make anything available to us. Before we go into the analysis of the guides, I want to say something about 3 anomalous guides and 2 guides that stood out to us. So on the left-hand side of the screen, you can see what one trust provided to us as a guide, which amounted to a series of picture exchange communication symbols with headings. I think this is one of 3 or 4 sheets that they sent to us. So whilst PECs, or picture exchange communication symbols, are commonly used with people with learning disabilities, this document that was sent to us made really very little sense as a standalone document, and it was very hard to see how this resource could be meaningfully used with a patient. So traditionally, these are symbols that people with learning disabilities with maybe little or no verbal communication might use to request something. So it was difficult to make sense of why these were being sent to us, and essentially represented an anomaly. If we then look at another guide that was sent to us, this was one of 2 pages which discussed restraint, and that was sent from another trust. Once again, it didn't really reflect the overarching principles to inform patients what might happen to them and why, nor about their rights or where to go for support. It also isn't traditional easy read. So that guide was also considered an anomaly. And then 2 trusts sent through the Department of Health and Social Care's Easy Read Patient Information Guide to Cheney's Law, which is pictured there on the right. And this guide explains Cheney's Law comprehensively, and it works through the 11 quantitative ratings. However, it doesn't explain anything about a local context or what might happen to a patient in that particular trust. I guess with this last one, it is perhaps better for trusts to offer this than nothing at all, but it does omit key information that is critical for people to understand their time in a mental health ward. So these guides were not quantitatively or qualitatively analysed because they didn't meet basic requirements. They're not discussed further in this report, but it does lead us on to a recommendation, which is to provide local information using standardised easy read formats. So as those 3 guides from 4 trusts were taken out of further analysis, that left us with 14 guides from 14 trusts. Before we look at the 14 guides together, we wanted to highlight 2 guides that were very notable. And before I move on to those pages, I need to give a content warning because some of the illustrations and pictures are potentially triggering for people with lived experience of violence or intimidation. So these 2 guides scored very highly in terms of quantitative analysis as they covered nearly all of the relevant topics. However, we are highlighting them from a qualitative perspective, and the online report breaks this down in more detail. And so we'll start with this guide from Trust 39, which had 3 areas of concern. Firstly, it was quite confusing who the guide addressed, as the guide would interchangeably address carers and patients, making it quite difficult to follow. So, for example, in one section, it said, you can help to write a PBS plan. And immediately afterwards, it said, we can make decisions about what we want to happen to us in the future. So the first sounds like something said from a staff member to a patient. And the next phrase sounds like it is patients saying that to each other. So the interchangeability with who the guide addressed made it very difficult to follow. Secondly, there were concerns around legal misinformation. So there's some examples here on the page on the left-hand side. This is a page which is explaining the human rights of patients in relation to restraint. You'll see on the third box down that it says, under the human right to life, they have said use of force is always accepted in law. Now, I'm presuming that what was meant to be communicated there was that the use of force should always be accepted in law. But that is not what the guide says, and therefore is essentially incorrect and negating a patient's rights rather than upholding them, which is the right, of course, to complain and to ensure that somebody is treated correctly in relation to the use of force. And you can see some other examples on the page there where the human rights of the patient are being either poorly or inaccurately communicated. And then the third concern was around the communication of the complaints process. So this was communicated over 12 pages. The guide was 36 pages in all, and the last 12 were given over to complaints process. And essentially, the guide went through multiple different ways, means, and routes to complaint, which meant that by the end of the 12 pages, it was very difficult to work out what procedure a patient should be taking. You'll also notice on the screen that the booklet started with this sentence, this booklet was made by people like you and staff. So that kind of language, which the report unpicks a little further, is deeply othering, implying that staff are not like you, the patient. And so the lack of care taken over language really made this guide very, very concerning. Then secondly, there was this guide from Trust 7. So they were the only trust to have produced an easy read version of their use of force policy. And it was at the time available on their website. It may have been taken down now. You can see here that the language and the illustrations are very concerning. So it is notable that they are the only trust that appears to have met this recommendation, which was to produce an easy read version of their actual policy. And they had another guide to the use of force that drew heavily on the content of this policy document. But you can see that the content is high risk for triggering a trauma response. And you can see from the box on the right that parts of it are written as if it is the reader themselves, so the patient who should be implementing the policy. So it says at the top, you must take action as soon as possible to stop people from becoming violent, which of course is not at all what we would want patients to be attempting to do. So the published report goes into more detail on these 2 guides and the concerns around them. For now, we'll simply move on to the recommendations that these guides prompted. So recommendation 3 is that the information in the guide should address the patient. Recommendation 4 is that the information in the guide must uphold the law. And recommendation 5 is that the guide must use inclusive and safety promoting language. and images or illustrations. So we analysed the remaining 14 easy-read guides to the use of force in terms of content included under a quantitative analysis. So all guides covered the first 4 basic content requirements, which you can see listed on the page: when force can be used, why force might be used, types of force, and complaints. And then on the right-hand side of this table, you will see the topics that guides mentioned commonly: care planning, debrief, and co-production, and then the topics that were mentioned infrequently across the guides. It's worth remembering that these are out of the 14 guides analysed, but of course those are from 48 trusts. So when we see that 6 out of 14 patient guides talked about advocacy, which is a core right for someone in a mental health ward, this translates to 13% of all of the 48 trusts that are communicating to patients with learning disabilities about their right for an advocate. So the qualitative assessment, which we'll move on to now, is, as already mentioned, presented under the 6 inquiries listed. So let's move on to the first qualitative criteria, definitions of restraint. So subsection 6 of Cheney's law defines restraint, and then Restraint Reduction Network have worked on an adapted and accessible definition of restraint using clear terms. They define restraint as making someone do something they don't want to do, or stopping someone doing something they do want to do. So we took Restraint Reduction Network's definition as a benchmark, as it is a clear and unambiguous definition of restraint. We found that 1 guide adopted this definition, and you can see that on the right-hand side of the screen. 2 paraphrased it. 2 trusts talked about restrictions as actions that staff are allowed to use to limit or restrict your liberty when you are distressed. You can see that that kind of a definition has different implications and connotations. 1 trust used opaque language, and they talked about things we do to prevent harm to people and to keep you and the ward safe. And you can see that there's a problem with that definition, in that in no way does it imply that physical restraint might be used in order to achieve that. We found that 4 trusts defined restraint only in terms of physical restraint, so putting hands upon a person, and 4 trusts did not provide any definition. So recommendation 6 is that the guide should adopt Restraint Reduction Network's definition of the use of force. Let's move on to whether the patient guides addressed the type of force. So Cheney's law lists 4 types of restraint as physical, mechanical, chemical, and isolation, and every guide provided some information about types of force, but the quality of the information varied greatly. So we found that 5 trusts listed the types of restraint used, but they didn't detail types of physical holds or what that might actually equate to. We can see on the screen an example which offer simple definitions of the 4 types of restraint. We found that 9 trusts listed the types of restraint and also went into some detail about types of holds. Trust 44's guide is shown, and this was one of 2 guides to use the misleading phrase that restraint can never be used to hurt you or make you feel bad, and that's in bold there in their guide. The difficulty with that phrasing, of course, is that we're assuming it means that restraint should never be used to hurt you or make you feel bad. By stating that it can never be used to hurt you or make you feel bad, it potentially invalidates a patient's experience when that does happen, or when restraint is used in that way. You'll see these photos down the bottom of the screen that are illustrating supine and prone restraints, and those photos warranted some closer inspection. So we enlarged those images, and it clarified that they appear to be pictures of people standing up against a wall that have been turned 90 degrees. Images are really powerful in these guides, and communicating about types of force should leave a patient with clarity about what an authorized restraint should and should not look like. So images like this create confusion, not clarity, as they look more like a man posing for the camera and a woman who has fallen over. So we're recommending that all types of force used should be clearly explained and illustrated with care in a way that isn't ambiguous or confusing. So if we move on to think about how the patient information guides discussed the patient involvement in care planning, the statutory requirement says that the guide should detail how patients, their families, carers, and independent advocates will be involved in care planning that sets out the preventative strategies to the use of force. That's in Section 3 of Cheney's law. So we found that 6 trusts addressed patient and sometimes family involvement in care planning, but with varied quality. We found that 5 trusts mentioned care planning as part of their post-incident review process. It wasn't clear if patients were facilitated or encouraged to contribute to their own care plans from the point of admission. And 3 trusts did not address involvement in care planning at all. So we have a couple of examples on the next screen. The first example is from Trust 5. It's from a section addressing post-incident information. And you can see from the tone that it is adopting a more paternalistic rather than a collaborative tone. So staff will review your observation level care plan and discuss this with you to see how you may want staff to keep you safe if there are further incidents. And so very much communicating that staff are in control rather than a collaborative tone. In contrast, we can see Trust 38's guide. Your care plan should say how you want to be supported if we have to use restrictive interventions. So we will write your care plan together. So more of a sense of collaboration. So recommendation 8 is that patient collaboration in care plans should be explained and facilitated. Let's think about post-incident debrief and how that showed up in the patient information guides. So the statutory requirement is that the patient guide should detail how patients, their families, carers, and independent advocates will be involved in post-incident reviews following the use of force, and how the impact on the physical or emotional state of the patient would be reflected in their follow-up care. We found that 11 trusts either alluded to or explained their debrief and post-incident learning process. And we found that 3 trusts did not mention debrief at all in their guides. There's an example on the screen, which you can see on the right, which is a good example of how simple language can be used to explain the debrief process. In Report 1, we discussed Restraint Reduction Network's 2 stages to debrief in Section 8 of that report, which, whilst not statutory, is based on the science of the stress continuum. It explains that best practice for debrief is that there are 2 stages. Firstly, a post-incident support, which is focused on the immediate physical and emotional well-being of those involved, and then a later post-incident learning exercise, which happens sometime after the event, usually 24 to 72 hours after the event, which is where the focus is on learning what caused the distress and how to prevent future incidents. The importance of that dual debrief process is based on the neuroscience, which helps us to understand that after an episode of stress or de-stress, all of those involved, so that is staff, patients, and witnesses, until they have regulated their emotion again, are unlikely to be able to access the parts of the brain that would enable them to reflect and learn from the incident. And so without a 2-stage debrief is unlikely to be effective as a reflective or learning tool. So we looked at the patient information guides and whether they were reflecting a 2-stage debrief, and we found that 9 of the 11 guides mentioning debrief blurred those stages together as the one on the screen does. So you can see from the example that it's using good language with a collaborative picture, but they say that we will make sure that you're okay, you can talk about how you felt, and then we will work with you to think about how to stop an incident happening again. So that blurring of those stages together is likely to be ineffective. So Trust 10's guide did cover the 2 stages of debrief and post-incident learning, and they did so in simple language. So this is a page which is essentially their introductory page to explaining debrief, and it's broken down into step-by-step information over 4 further pages. So the content covered in the guide is good in that it uses 2 stages and straightforward language. but the quality of communication really needed improving to comply with Easy Read guidance. So recommendation 9 is that two-stage debrief should be implemented and explained. So if we move on to think about advocacy, so 5 trusts mentioned advocacy, but either didn't explain what it was or didn't explain how a patient could ask for an advocate. 8 trusts didn't mention advocacy at all in their guide, and just 1 guide explained what the advocacy service was and how to contact them. On a screen, you can see we're highlighting this because of the way in which they have left space for names and phone numbers, including the advocate, suggesting that the guide was not simply shown to a person on arrival, but left with them as a personalisable document, which sets a better tone. So recommendation 10 is that the right to have an independent mental health advocate if detained under the Mental Health Act should be explained and local contact arrangements provided. So let's move on to think about concerns and complaints. So all 14 guides had something to say about concerns or complaints. 7 trusts provided information about who to approach alongside contact details, and we can see a good example on the left from Trust 23. So they do provide phone number and email address in their guide, but that has been blocked out to anonymise it. We also found that 3 trusts informed patients that they could complain, but didn't explain how or provide any contact details or means of doing that. And we can see Trust 28's example is illustrative of that. So 2 guides only gave the option of talking to staff to make a complaint. Trust 10's guide is an example of that. They prefaced their statement about complaints by stating that staff are here to care and look after you and keep everyone safe. You can see that in the first box on their guide. And this implies that a patient perhaps needs to disagree with that statement in order to persist in their complaint. So it's problematic to couch complaints alongside statements such as that one. We can also see that the images are problematic. So the final image is of an angry-looking person speaking censored words. And this could be understood either as the person complaining being angry, although it doesn't require someone to get angry in order to complain. Or it could just as easily be interpreted as the response from the staff member who is receiving the complaint. Either way, it is potentially misleading. So recommendation 11 is that guides clearly state the right for patients to make complaints and provide local contact details so that patients know how to make a complaint. So some concluding thoughts. The Mental Health Unit's Use of Force Act 2018 gives clear stipulations about the provision of information to patients with particular regard to people with learning disabilities. The ethos behind the requirement to produce accessible guidance for patients is based on the many personal stories captured during the work done in the writing of Cheney's law. The patients had no prior knowledge that they might be restrained, why that would happen, nor the sorts of restraint that might be authorised. Without that knowledge, patients and families have no way of knowing whether what is happening to them or others is proportionate or legal, nor how to take action or find support. Thus, the provision of appropriate information on the use of force to help them navigate their time in a mental health ward is essential. As already noted, 18 out of 48 trusts had something that was made with people with learning disabilities in mind. The concerns raised in this report about what some of those trusts have produced in their guides needs to be weighed against the apparent absence of any resource from the remaining 30 trusts. We would also acknowledge the existence of an Easy Read leaflet or guide does not guarantee that it's used. And vice versa, the fact that we were not able to find or access an Easy Read guide doesn't mean that a trust doesn't have one and is using it. There are some challenges to producing a Easy Read guide, particularly on this topic. It's challenging to produce one that is non-traumatizing and non-oppressive on a topic that is inherently traumatic for some people. But even so, some of the better examples illustrate that it is not unachievable, and so it was very disappointing not to find an exemplar Easy Read guide that we could recommend to other NHS trusts that don't currently have one. And once again, it's important to remember that 2,000 people with learning disabilities and autism are detained in mental health wards in the UK every day. And despite numerous efforts from many directions, this figure does not seem to change. If it did change, research and reports like this would be redundant. However, until this happens, we have a responsibility to ensure that people with learning disabilities who are detained on mental health wards are equipped and empowered to navigate their rights and have access to all the support that should be made available to them. It is a completely reasonable requirement that any person admitted into a mental health ward be equipped to understand that they might experience or witness restrictive practice, what those restraints or restrictions might be, and how they can identify when something goes wrong. They should also know their rights, particularly how to contribute to their own care plan, how they will be supported after witnessing or experiencing restraint, how to speak up when concerned, how to access support such as advocacy. The provision of this information in accessible formats is not radical, but basic human respect. Thus, going forward, we feel that there is an imperative to act on these findings and co-produce appropriately illustrated, safe and accessible patient information on the use of force. We finish with 11 recommendations. Together, these recommendations should steer NHS Trusts to produce compliant and helpful patient guides for people with learning disabilities. If you'd like a further conversation about this research, or indeed about co-producing and disseminating effective patient guides for people with learning disabilities, or if you're interested in this work, please feel free to get in touch.